Our dear friend Eduardo Ramacati has asked us several very valuable questions regarding using the Caprini score, so that the purpose of this video is to further discuss these problems.
Hello, Eduardo. So one of the things was, if I was to get away with any Caprini version, the one you would use would be 2013, is that correct?
2013, because it's been validated in orthopedic patients, and it shows a nice clear line which has subsequently been further substantiated that for 9 and below, aspirin works very well for total joints, and if it's 10 and above, a standard anticoagulant is superior.
Okay, so that brings this other idea of the validation of the score within tiers of which kind of surgery we're talking about. So that was nicely presented on that Lowestoft paper you like to quote. I'll put the reference on the bottom. So different thresholds, different actions to take that to a different extreme. So what do you do for, let's say, varicose veins? So is it dismissible risk, or some of them need prophylaxis?
I think some of them need prophylaxis, and we don't know the total answer, and the threshold paper didn't really address that. But what we do know is, based on the studies that were done by Lowestoft, he suggested a score of 7 and above gets prophylaxis, unless the patient gets above 10, and in that case, 30 days of prophylaxis, especially for history of DVT. Now, the Michigan papers show something very similar. They use 8 and above to give 7 to 10 days of prophylaxis, but then again, 30 days is recommended for people with very high risk factors, such as a history or family history of venous thrombosis.
So even for varicose veins, 2 tiers, more than 7, more than 10, but the answer is yes, they do deserve prophylaxis, and we have proven really the Caprini score does actually help those individuals. Harder question. So we do agree, and I think we do have great agreement. If you have a post-surgical patient, whatever the surgery, 5 and above, they deserve prophylaxis. You're gonna go for the 7 to 11 days. Patients who are 9 plus, you're gonna go ahead and do the extension based on good data for the 4 weeks and a full month of therapy. 0 to 2, they are so low risk that we're not gonna actually benefit them from anything. But what about those 3 to 4 individuals? So what do you do with those?
I think in most patient groups where the incidence is so low to begin with, giving them anticoagulation doesn't really change that. And although complications are relatively rare, I think that puts a patient in unnecessary risk because of the chance of benefit does not exceed very much, because they already have a low risk to begin with. It's hard to lower a low risk.
Hard to lower a low risk. So somebody asked me to be honest with myself. I mean, sometimes we have to say I don't know when I don't know. We do not have clear benefit on the 3 to 4s, but I do argue many of those 3 to 4s that actually have to stay in the hospital, they're probably not a 3 to 4 anymore. I mean, they have acquired a complication. So the value is make sure that you rescore that patient.
That's right. So that's really very important, is that those patients must be rescored, because there always is the danger of those additional risk factors. And I don't see too many papers that use the risk score in a dynamic fashion, and that's a terrible mistake. In addition to that, relying on retrospective data where you don't know who asked the questions or if they asked all the questions is a really serious problem. And 2 special things about the Caprini score, which I think need to be re-emphasized. It's the only score that tracks obstetrical complications. Now, we need more data, but we know that some of those people with obstetrical complications later in life may still have a thrombophilia defect. And then family history of thrombosis. Very, very important to track family history of thrombosis in all 3 generations. And the latest data from Scandinavia in 750,000 patients pretty much shows us that we better take a look at that. Not just thrombophilia, because thrombophilia, only 30% of people with a DVT have a positive marker.
So I hear you. Family history as a great marker. Eduardo, hopefully this answers some of those questions. Next time you play with us. Take care.
All the best, Eduardo. Keep up your wonderful work.
Go ahead, your role.
Yeah, so